Also note the displacement in varus and valgus, and note whether is there any impaction of the articular fragments. Why? Why is it important? Because that will suggest me, like in this case, I can see this impacted fragment in a Pilon injury, but the anatomy of this intra-articular fragment, which has moved proximally, is not very clear. However, when I do these coronal and sagittal CT scans, it shows me where my fragment has gone. So the importance of understanding these fragments by a CT scan is an important assessment to be made radiologically, which will help us in planning the treatment of such cases. Coming to malleolar fractures. Of course, we describe them unimalleolar, bimalleolar, or trimalleolar, but what we are doing for them? We are doing routine AP lateral view, and we are also adding a special view called a mortise view. Now, this mortise view is taken in 20-degree internal rotation, and this is how it looks, the AP and mortise view. And what we are looking in the mortise view? We are looking at Shenton's line, we are looking arcuate line. A break in the Shenton's line will suggest a syndesmosis disruption. A break in the arcuate line will suggest us fibular shortening. So that's how these kind of special x-rays and these assessments, they give you an indication what you are handling, and then you plan your treatment accordingly. Malleolar fractures have been classified in two different ways, the Lodge-Hansen, which is based on injury mechanism, and the Weber system, which is based on the level of fibula. So the Lodge-Hansen system has a first word which describes the position of the foot, and the second word describes the deforming force. And to see now how these nomenclatures are correlated, we have this Weber A type of injuries where the fibular fracture is below the distal tibial articular surface. And in stage 1, you'll get only isolated fibular fracture. But if the deforming force continues, it hits the medial malleolus, produces a vertical kind of shear fracture of the medial malleolus. So these are supination adduction injuries according to Lodge-Hansen. But there is no syndesmosis injury in these kind of fractures. This is Weber type B. Now, in Weber type B, the fibular fracture is starting at the tibial articular line. It is before the fibula fractures, there is a disruption of the anterior syndesmotic ligament because the talus is rotating externally. So this is, according to Lodge-Hansen, these are supinated external rotation injuries, and these are called stage 1, whereby the ligament ruptures, stage 2, when the fibular fracture takes place. And if the force continues, we go on to the stage 3 and stage 4 of the Lodge-Hansen. And with stage 3, the posterior malleolus fragment or the posterior syndesmotic ligament rupture, any of these takes place. And the stage 4, the medial malleolus fractures. So you have a trimalleolar injury kind of a thing with a complete syndesmotic disruption in supination external rotation stage 4 injuries. This is one good example where you can see all the stages in one particular trimalleolar injury. And then comes the Weber C. Here, the fibular fracture is starting above the tibial articular line. So this could be, this is always happening with pronated foot and with external rotation injury or with abduction. So here is an example of pronation external rotation injury taking place, producing a high fracture of the fibula. The syndesmosis ligament in this situation usually can rupture directly, or sometimes it takes a fragment of the tibia from the anterior talus or from the posterior malleolus. And these are the different patterns of syndesmosis disruption which can happen with supination external and pronation external rotation injuries. So the role of CT scan in these kind of injury becomes important. Rambelt has classified these syndesmotic disruptions into type A, B, C, and D. And these kind of detailed study with the CT scan gives us a great guidance in planning our treatment and doing a good internal fixation after reducing these all components of injury. Before I stop talking about malleolar fracture, one word which I want to tell everybody, that if you find only medial malleolus fracture on AP view, and you find another posterior malleolus fracture on the lateral view, and you see an intact fibula, beware. See this example? Only medial malleolus and a posterior malleolus. Now, in this situation, it is always important to take a full-length X-ray, and you find here a high fibular fracture, so-called a variant of PER, named as Masonov fracture. So include the knee joint if you are looking into, if you're suspecting your injury to be PER kind of an injury. Talking a bit about sprains, where the X-ray is negative, not showing you anything, but the clinical presentation is nearly same: swelling, pain, inability to bear weight. Well, all these injuries, they would resolve with conservative treatment most often, but if there is a failure to resolve, then you need the help of MRI. MRI is a very, very good tool whereby in a fat suppressed images and proton density images, you can see the anterior talofibular ligament very clearly, and you can see these CFL quite clearly in the axial sections as being seen here, here, and here. And then next is injuries to the medial collateral ligament. So beautifully you can see in the coronal views the whole of the medial collateral ligament, the deeper part and the superficial part. And that's how in ligament injury assessment, MRI becomes an important tool. Talking about a little bit of non-traumatic condition, the osteoarthritis of the ankle is easily diagnosed on the basis of reduction of joint space, presence of osteophytes, and irregular articular surfaces. Whether it is a post-traumatic degenerative arthritis, there also we'll find the same changes, and except in the post-infective, which maintains the articular space for a long time before it goes out. So in these kind of situations, to make an early diagnosis, MRI is very helpful, which shows the subchondral cysts in the PDFS images. Similarly, to diagnose AV and talus, whenever we are suspecting it, though we are seeing a bit of sclerosis on the superior margin of the talus, but when we do an MR, the proton density images are able to tell us not only the diagnosis of AV, but also the extent of the avascular necrosis happening in the talus. Coming to the foot, I would divide the foot into hindfoot, midfoot, and forefoot. And first, let us take the hindfoot. A very common reason for hindfoot pain is subtalar arthritis, and is seen on the lateral view by the diminution of subtalar space. But more sensitive and more specific test is to do an MRI and look at subchondral edema and articular cartilage involvement on the PDFS images. Calcification on the posterior aspect of calcaneus like this is always suggestive of degenerative Achilles insertional tendinosis and the calcification happening in the distal part of the Achilles tendon. So the posterior pain, whenever you have, and you have this presentation, this is the diagnosis which comes to your mind. Similarly, the plantar heel pain, and you see this big spur on the plantar aspect. So these are associated with the plantar fasciitis. Looking at calcaneus lateral view and calculating these Bowler angle, Gisand angle is an important tool whenever we are dealing with calcaneal fractures. Another view which is very important in calcaneus is axial or Harris view. That's how we take it, the axial view, and that's how it looks like on the X-ray. So to illustrate, here on your right side is a case of calcaneal fracture which has been fixed internally, and you can see that by doing an internal fixation, the heel width has been restored to normal. While on the left side, in a patient of bilateral calcaneal fracture, you can see a broadened heel in the axial view. So these kind of informations are obtained on the axial views or the Harris views of calcaneus. The evaluation of intra-articular fracture of calcaneus now is incomplete without the help of a CT scan. So when we get the CT scan done, you get such large, so many films. So what you got to see in these? Well, what you have to see is the pattern of the injury, knowing your sustentacular fragment, knowing your tuberosity fragment. And these kind of analyses are helpful in planning the treatment, in classifying your injuries. The classification nowadays being followed is based on CT scan, and this is Sanders classification type 1 to 4, which is based on the coronal view in the broadest part of the talus. And you have these classification into type 1, type 2, type 3, and type 4, depending upon the fracture lines which are present on the calcaneal sides. Next is the talus fracture. The lateral view of the hindfoot is able to tell us the different patterns of talus fractures, and they have been classified Hawking type 1 to type 4, depending upon whether the fracture is displaced or undisplaced, or whether it is dislocated ankle joint or dislocated talonavicular as well as ankle joint. So just a broad overview of these talus fractures, Hawking classification. The important thing in talus is to know that there exists a special view called canal view. Canal view is a view which shows you the talus in full profile and is very helpful in assessment of your reduction as we do this fluoroscopic examination of the talus peroperatively, and we check our reduction, that have we been able to reduce our talus well. So a simple post-operative examination by X-ray sometimes doesn't give you a very good information on how good your reduction is, but a CT scan assessment tells you that yes, you have been able to reduce your talus quite well, and the shape is restored, the subtalar joint and ankle joint are looking good. So CT assessment post-operatively and pre-operatively both for these kind of comminuted talus injury becomes very important. Hindfoot pain in a case of unresolved sprain is often due to tarsal coalition. So what you see here is a calcaneonavicular coalition. The calcaneal anterior process is continuous with the navicular by a bony segment, and this is called calcaneonavicular coalition. You can see it clearly in AP views, oblique views, and a subtle kind of calcaneal tarsal coalition is better seen on an MRI in the form of edema in the region of anterior process of calcaneus and by this beaking of talus at the talonavicular joint. Another important examination tool to understand whether in a standing position the heel is central, right under the tibia, or is it in varus or valgus, is a Salzmann view in standing position. So this more or less summarizes what all we need to see in the hindfoot. And we go on to the midfoot. In midfoot, we always order AP, lateral, and oblique views. And what we see, we want to see that the medial border of the first metatarsal is well aligned to the medial border, lateral border of the first medial cuneiform. And similarly, we want to see the medial border of second metatarsal is well aligned to the medial border of the middle cuneiform. And then we are also looking at the fourth metatarsal medial border well aligned to the cuboid, and third metatarsal well aligned to the lateral cuneiform. So these alignments, why do we need to see them? Because the subtle kind of midfoot injuries, so-called Lisfranc injuries, which bring about disruption of these alignments, are understood only once we make our eyes getting used to seeing these alignments. So here you can see in a Lisfranc injury, the alignment is disturbed. the alignment of the fourth is disturbed. So this is a less frank injury. And very subtle less frank injuries, you have to look into the medial cuneiform second metatarsal space and look for this flake sign, which is suggestive of a less frank ligament injury. The other midfoot injury, you can clearly see, of course, all the metatarsal injuries, but what is more important is not to miss a Jones fracture non-union, because this is the place where the fracture is very likely to go into delayed and non-union, and then you can watch the progress of the fixation, whether your fracture has got united or not. And then we come to forefoot. In forefoot, we prefer to take again a standing X-ray, and the first metatarsophalangeal joint is the most often subjected to osteoarthritic changes, because in our toe push-off, 80% of the body weight is carried by the first MTP joints, and appearance of these dorsolateral osteophytes is a very early sign of early osteoarthritis of the first MTP joint. We also call this condition as hallux rigidus, and this is visible both on the lateral and the AP views. And once the disease advances, you can see the complete obliteration of the first MTP joint space, and these are late stage 3 hallux rigidus cases. This is one of the X-rays of a gouty arthritis, which again involves the first MTP joint. You can see a lot of gouty cysts in the head of the metatarsal. Hallux valgus or the bunion, these are another areas where the standing X-rays are very important. Weight-bearing X-rays are very important for the assessment. And we try to calculate the axis of the proximal phalanx and the axis of the metatarsal and the angles substituted by them. Normally, it should not be more than 15 degrees. But if it is more than that, we know that it is a hallux valgus. And depending upon the degree of the hallux valgus angle, and then measuring another intermetatarsal axis, the metatarsal axis of first and second, which normally should be 9. So based on these two parameters, we classify our hallux valgus into mild, moderate, and severe varieties. So whenever you do hallux valgus, you have a case, you should be able to measure these two angles and describe the severity of hallux valgus. Weight-bearing X-rays, lateral view of the foot. It's so very important in most of the deformities, whether you are dealing with cavus deformity, whether you're dealing with flat foot deformities. So this is how we do a weight-bearing X-rays of the foot and take a lateral view. And what all we see? Sinus tarsi, of course. What is sinus tarsi? Well, it is a small opening of the tarsal tunnel lying just anterior to the distal fibula, and we can see here this is how a small opening should be seen in a normal X-ray. But if the heel has gone into valgus in a pronated foot, this gets almost obliterated. And if heel has gone into varus, you see a big hole and you see an open sinus tarsi. So that's how, looking at sinus tarsi, you get an idea whether you are dealing with heel varus or heel valgus. Another important thing, talar inclination angle on the weight bearing. So this is a talar inclination angle, which is very important to give you an indication whether you are handling a ankle impingement or you are handling a malunited calcaneus, in which the talar inclination reduces from the normal of 20 to 26 degree. So this is how you get an idea about the range of motion happening at the ankle and the impingement happening at ankle by knowing your talar inclination. And then there are other parameters like calcaneal inclination or the pitch, the Mary angle, so-called an axis between the talus and the first metatarsal, talocalcaneal angle, chyma, navicular cuboid overlap. These all parameters you have to understand. I mean, because of paucity of time, I can't go into details of each and everything, but they are important tools in assessment of various deformities of the feet. I will just cover a very commonly happening hyperpronated or the flat feet, where how do these parameters change in these. So if you see these hyperpronated feet, the talus second metatarsal angle, which normally should be 16 degree, is found to be increased in this case. Similarly, the Meary angle, which normally should be about 0 to 4 degree, is also increased in these cases. So, my dear friends, a lot might be missing, but the time, I think, is over. And I'm hopeful that I've touched upon the basics that a postgraduate should know, and we'll have another occasion to talk more about radiology. Thank you.